A very good afternoon to all of you. On behalf of MEU and SMS Medical College and the CPC team, I welcome you all for today's CPC. And to begin with, I would request all the dignitaries to kindly grace the dais. Dr. Deepak Maheshwari sir, Honorable Principal and Controller, SMS Medical College. Dr. Deepak Mathur sir, Professor and Head, Department of Skin and VD. Dr. Puneet Saxena sir, Professor and Convenor CPC, and Dr. Monica Jain ma'am, Co-Convener CPC and ADP Academics. All of you are requested to kindly grace the dais. It is also a matter of extreme pleasure and pride for us that our former additional principal and former professor and head of skin and VD, Dr. Dinesh Mathur sir, is here with us. So sir, we welcome you heartily. And now I would request Dr. Aradhna Sharma ma'am to please take over.
Thank you, Dr. Shruti. Good afternoon, everyone. So today is very interesting, unusual, and very rare case is going to be presented by a department of DVL, that is Dermatology, Venereology and the Leprosy. So without delay, I would like to request Dr. Deepak Maheshwari sir to address the gathering. Please, sir.
Thank you. First of all, I want to thank you all for coming here. But still, the attendance is very thin. So from next time, it should be made mandatory and some guidelines should be issued that everybody should be here. I think almost 500 PGs are here. 600. So, I recently visited the institute which जो बन रहा है इंस्टीट्यूट मैंने देखा अभी और वो इंस्टीट्यूट काफ़ी इम्प्रेसिव है. डॉक्टर दीपक माथुर ने जो काम किया है उसमें वो काफ़ी अच्छा है और मेरे ख्याल से जब वो बन गया तो कंट्री में एक नई चीज़ बनेगी. वो राज्य के लिए नहीं, देश के लिए भी एक बड़ी बात होगा. और मैं डॉक्टर दीपक माथुर का धन्यवाद देना चाहता हूँ और उनके डिपार्टमेंट का स्पेशली कि जिन्होंने इसको प्रोजेक्ट को कंसीव किया और जमीन पे लेके आए. आगे की कार्रवाई आगे में आप सबका बहुत बहुत धन्यवाद और बेस्ट ऑफ लक. थैंक यू.
Thank you, sir. Very well said. Because CPC is not for the only for this time to discuss only the one type of the case, but it is for the interaction for the all the departments which are involved and or not involved in this CPC. So it is requested from the CPC side. So please come as number as possible to attend the CPC. So this CPC might be successful in next coming time. So now I will request our convener, Dr. Puneet Saxena sir, for SOP.
Good afternoon, everybody. Principal sir, Dr. Deepak Maheshwari ji, Dr. Deepak Mathur sir, the PHOD of the skin department, Dr. Dinesh Mathur sir, the ex-PHOD and our senior and teacher. And I can see Dr. SM Sharma sir and Dr. I.T. Gupta and other senior people and dear students. So as very rightly pointed out, and time and again we have been speaking that the attendance is mandatory basically to make the CPC successful and we can benefit it. Not a matter of success, but everybody can be benefited. Not only those who are doing such hard work to present and to select the case and to prepare and present it, but all the PGs also can be benefited like anything. So I think the MEU, Dr. Monica Jain is here, who is the academics in charge also in ADP. She has just sent a message to all PHODs that the PG should attend, all the PGs should attend the CPC and should enter it into their logbooks. So I would request principal sir that if we can issue a circular to all PHODs to make it mandatory at least for the postgraduates after making all the necessary arrangements. And all the faculty members can also make. And it's not only the academic, we all can interact over here. We meet once in a month. So that is a very great opportunity to meet and interact with the administration and amongst ourselves also. And regarding this, the SOP, so we all are aware about the SOP now that the first 15 minutes are for the departmental progress and presentation by the presenting department. And then we do a multidisciplinary case. And we have been doing the very good cases up till now. And they all have been very rare and very nicely worked up cases. And being a premier institute in the country, we get a lot of clinical work. And I will request all the subsequent departments who are present, who will be presenting CPCs, to select very good cases and work them up very nicely, because these cases will be published and they are put on the website of the college also. So with that, I end here, and all the best to this department, which already is a shining star in this college and in the India. Thank you very much. So anybody who is present from psychiatry department here? Sir is here. So we have next CPC on 18th of July, 24. And there was some discussion about the timing of the CPC also. So we will discuss with principal sir, and as he says that we will decide about the timings also.
Thank you very much, sir. Now I would like to call upon Dr. Mathur to proceed for CPC.
It's indeed a great pleasure to welcome you all to this 10 CPC. The very mention of this 10 CPC shows that the CPC has been a grand success all through. And now I request Dr. Deepak Maheshwari sir, Head of Department of Dermatology, to present a bird's eye view of his department.
Good afternoon, everybody. Dr. Deepak Maheshwari, our principal, my senior Dr. Mathur sir, ID Gupta sir, SM Sharma sir, faculty members and residents. It is a matter of pleasure as well as a proud that today Department of Dermatology is going to present CPC. This is our medical college, and this is the Charak Bhavan where Department of Dermatology is there. This department was started in 1951 by Dr. M.P. Mathur. He was sent by the princely state of Jaipur to USA to study dermatology. After return back, he initially worked in the Department of Medicine, and then in 1951, an independent Department of Skin and VD was established. Fortunately, I had a chance to meet Professor M.P. Mathur Sahab. He was saying that one fine morning, the superintendent issued one dawat and pen, and they put it in front of me, then you are HOD of dermatology from today. This was the way which Department of Dermatology was started in the Department of Medicine only. Department has grown in its size since then and has contributed remarkably in the field of dermatology. These are our head of the departments. I am 10th in number. Current faculty members are, we are having 5 senior professors, 1 professor and 3 associate professor. Our 4 vacancies of assistant professor are lying vacant. Currently, the department has 9 faculty members, 39 postgraduate students and 5 senior residents. This is our OPD in the full time. It is dealing with a huge number of patients in a day. Every year, around 4 lakhs patient visit in OPD. If we divide 4 lakh by 365, it comes to be more than 1,000, including Sunday and GH. In last year, in 2023, we have detected 243 new cases of leprosy, and total 1,333 patients of STD was registered in our STD clinic. We have got 30 beds in male ward and 30 beds in female wards. Our department provides specialized care in the field of dermatology, sexually transmitted diseases, leprosy, cosmetic dermatology, and dermatosurgery. We are equipped with the most advanced technology like laser, phototherapy, cryosurgery, HIFU machine, multi-platform harmony, IPL. Along with this, various specialty clinics are also being run in the department. At present, we are running 11 specialty clinics. In some of them are running every day, some are weekly. In this way, we are covering all the specialized care in the field of dermatology. This is our STD clinic. This is our leprosy clinic. We have got specialized facilities like radiofrequency, chemical cautery, chemical peeling, mesotherapy, vitiligo surgery, microneedling, PRP, phototherapy, minor cutaneous surgeries, nail surgery, and laser therapy. Approximately 25,000 minor and major procedures are done per year in our department. This is our minor OT. This is our procedure room. This department has been expanded and modernized with laser, IPL, and HIFU machines. All the machines in our department are US FDA approved. This is our achievement. Our seniors, myself, my faculty, we all had view that we should have the best equipments. And still, we are since last 5 years, we are using lasers, and lasers are performing very well. कभी ऐसा नहीं होता कि लेजर खराब हो गई है, ये खराब चल रही है, ये नहीं चल रही है. We have got ND-YAG laser for pigmentation and tattoos, CO2 laser for scar, diode laser for hair removal. We have got excimer laser for the treatment of vitiligo and psoriasis. We have got Harmony XL Pro for the treatment of vascular lesions. We are the first department among the all government medical college in India, and we are all having US FDA machine, at least lasers. Now this is our FEMI Lift CO2 laser machine, and we are using this machine for skin regeneration, treatment of scars secondary to acne, actinic and seborrheic keratosis, warts, mole, skin tags, xanthomas. This is our diode laser, which is used for hair reduction. This is our Q-switch ND-YAG laser. It is the latest model, and we are using this machine for pigmentary lesions, scar, tattoo removal, skin laxity, carbon peel, and body toning. Now, very important thing that the cost of every procedure, it is because they are all cosmetic procedures, so the cost is very less. For example, for hair reduction, in the market, all cosmetic clinic charge 3,000 to 5,000 rupees per sitting, but here we are charging 775 per sitting. And if somebody goes for whole body hair reduction, they charge around 50,000 rupees. It comes to around 4,000 to 4,500 rupees. These are our another lasers. This is our Harmony laser. This is used for pigmentary lesion. Its rate is under consideration in the government about the cost of the procedure. This is our excimer laser. Now this is high intensity focus ultrasound HIFU machine. This is used for skin regeneration. This is our micromotor machine. This is used for vitiligo surgery. This is our cryosurgery unit. This is used for cryotherapy procedures like removal of the warts and other growth tissue disorders. This is our trico scan. This is a microscopic hair analysis device we are having in the department. We are having dermatoscope. Dermatoscope is used for skin analysis. We are having narrowband UV whole body chamber. We are having UVA chamber. Both type of phototherapy we are doing in our department, and this we are doing free of cost. This is our iontophoresis machine. This is used for the palmoplantar hyperhidrosis. We are the department in the country which has got penta-headed microscope. By one microscope, our 5 people can see a slide, and it is the one of the best teaching tool in our department in the dermatopathology. As far as academics is concerned, department is imparting postgraduate teaching since 1982. Presently, we are having 30 PG students per year. We have exhaustive teaching programs. We have got 5 days a week teaching program. It is from 8 to 9 in the summer time and 9 to 10 in the winter times. We are having journal club, seminars, tutorial, case presentation at dermatopathology discussions. We have got monthly internal assessment for our postgraduates. This is our well-equipped seminar room. Now, the important achievements, our head of the department, Dr. N.K. Mathur, started PG course during his tenure. He is the pioneer in the treatment of leprosy as far as zinc is concerned, he's got a large number of international publications in zinc in leprosy. He has got international publication on Langerhans cells in leprosy. Dr. Rishi Bhargav, our ex-head of the department, has given name to Jaipur by inventing a block, Jaipur block, in the treatment of post-herpetic neuralgia. Our Dr. Dinesh Mathur sir, who is present here, he is the pioneer for starting AIDS control program in Rajasthan, and he has received Lifetime Achievement Award for his work on HIV and AIDS. Dr. Ashar Shukla, our ex-HOD, has illustrated textbook in pediatric dermatology. Dr. U.S. Agarwal, our ex-principal and head of the department, has given a ear sign for tinea capitis in childhood. He has also received Sher-e-Kashmir Memorial Sheikh Abdullah Award, Ranganath Memorial Award, and he has got remarkable tenure as principal SMS Medical College since 2015 to 18. Myself has got small contribution. I have done a work on defective fat in hair and syndrome, and I was awarded the Merit Award by the Government of Rajasthan by Honorable Governor in 2017. The important event organized by the department, this department has organized National Conference of IADVL in 1992, 2012 under the chairmanship of Dr. Dinesh Mathur sir, and 2022 we had e-conference, and now we are coming with the Dermacon 2025, our national conference, with a membership of around 17,000, and we are expecting around 9 to 10,000 delegates this year in the next year in February 2025. We are organizing our conference on 6 to 9 February at JECC Jaipur. We have organized large number of our state IADVL conference. We have also organized international conference in dermatopathology, and we have got workshop for dermatosurgery for the student under the leadership of Dr. Dinesh Mathur sir, and we have got large number of public awareness rallies and programs. These are the programs like leprosy awareness, psoriasis awareness, and we have got other awareness program, Vitiligo Day. We have organized the social events. We have in the sports also, we people have organized our departmental sport meet, and in 7 decades we had a good pavilion for the dermatological diseases. A number of faculties hold respectable position in the state, national level in our association like IADVL and ISSTD and other organizations. Research and publication, this department has continuously contributing to the literature by writing in books, and various papers are published in index, national, international journal. During last 3 years, we have got 32 research publications from our department in various national and international journals, and department has been honored with maximum number of best research paper award in our college, that is 6 times. Now, future upgradation, Department of Dermatology has been upgraded as Institute of Dermatology in budget announcement 2022 and 23. This Institute of Dermatology will be second in world. After Institute of Dermatology at London, the work of Institute of Dermatology is under progress. I requested our principal sir, and he has also visited the center, and the work is probably will be finished by the end of this year. This is the work which is going on in Institute of Dermatology on the first floor of the Charak Bhavan. And this is the list of publication by our department. Thank you very much for this patient hearing.
Thank you, sir, for so beautifully telling us about all the achievements of Dermat Department. Now, continuing with the saga, our Honorable PNC, Dr. Deepak Maheshwari, sir, would love to announce some proud new achievements of the Institute.
Sorry for interjection. Dr. Deepak Mathur, we are really impressed by your department and your achievements. You are doing a lot of clinical work, as well as your advances in the field of treatment as well as education. He has done one interesting thing also, which I think should not get unnoticed, that he started charging for some procedures. So I am trying to make a consensus in the government that we should we should start charging for some elective procedures. In next few days, I am consulting most of the HODs about this, and I think this is going to be a new beginning. I will also very pleased to announce two things. Our alumni have created two good monuments in our campus. First is PC Dandiya Sports Complex. It is a very beautiful facility with all modern equipments for exercise. And I request my PGs to take care. Please maintain that complex because I need support of students to maintain for maintenance of the facility. And the second thing is Daulat and Rashmi Bansal Reading Hall, which also can accommodate 450 students in a go, and it is equipped with all modern facilities. So these are two good things, and we are trying to take alumni's help for students. I have discussed this with the alumni's that whatever funds they will give us, we will only invest in student-related activities. Thank you.
Thank you, sir. Now with this, we move on to the much awaited case for today, and I invite Dr. Neha Chaudhary, second year resident dermatology, to present the case.
Thank you so much, ma'am. Good afternoon, everyone. After the introduction of the department, without much ado, let's start with the case presentation of 30-year married female farmer by occupation, rural area of Swai Madhopur district, belongs to low socioeconomic status. Came into our OPD with the complaints of painful erythematous to hyperpigmented ulcerated lesion with overlying scape present over multiple sites since 9 years, regurgitation of food from nose since 3 years, and change in voice since 3 years. She was apparently asymptomatic 9 years back when she developed a small erythematous to hyperpigmented solid elevated lesion over the forehead after having a thorn prick at the same site 1 month back. The lesion started insidiously as an asymptomatic papule, then slowly progressed in size to involve most of the forehead. Over the period of 6 months to 3 years, she noticed multiple similar lesions at face, like both cheeks and chin and other body parts including back, both upper and lower limbs and buttocks. With time, these lesions developed small projections giving them a warty appearance, and they ultimately ulcerated in center to form crust over them. During the course, she also noticed depression over the nasal bridge along with hole over the palate. Initially, the lesions were asymptomatic, but after the appearance of ulcer, lesion became painful. She was also having regurgitation to solid and liquids as well as change in voice. She denied any history of chronic fever, weight loss, chronic cough, dyspnea, lower backache, photosensitivity, recurrent oral ulcer, joint pain, persistent diarrhea, recurrent skin and soft tissue infections, muscle weakness, sensory loss at any part of the body. She also denied about tuberculosis in herself, family, and her close contacts. She also denied for genital ulcer and mucocutaneous lesions, which were suggestive of early syphilis. There was no history of similar complaints in the past, no history of diabetes mellitus, hypertension, asthma, surgery, drug allergy, any immunosuppressive drug, and immunocompromised state. Patient was vegetarian by diet, non-alcoholic, non-smoker. Her bladder and bowel habits normal and has normal pattern of sleep and appetite. She is gravida 2, parity 2, zero abortion, and has 2 live births, and her menstrual cycle were regular. Now come to the general physical examination. A fairly built and nourished female, which were well oriented to time, place, and person. Her vitals, including pulse,
blood pressure, respiratory rate, temperature, and oxygen saturation, which all were within normal limit. There was no sign of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Systemic examination include central nervous system, cardiovascular system, GI examination, all were within normal limit. Respiratory system on inspection, saddle nose deformity, palatal perforation was seen. Rest of the respiratory system examination was unremarkable. Now come to the most important part of examination, which is cutaneous examination. As you can see in this picture, multiple, large, well-defined erythematous to hyperpigmented hyperkeratotic plaque was present over the face, forehead, involving bilateral cheeks and chin also, and the same type of lesion also present over the bridge of nose. Some ulceration and brownish yellowish crusting also present over the lesion, and some of the plaque were associated with central hypo and depigmentation with surrounding hyperpigmentation. Similar lesions of varying size were scattered over the back, buttocks, and both upper and lower limbs. Since our patient had nasal destruction and palatal perforation, hence we sought reference from ENT department. Now I would like to Dr. Shubham Agarwal sir from ENT department, associate professor, for further discussion.
Good afternoon, one and all. So continuing on the talk, we started with the ENT examination. The patient was referred to us from the dermatology. So on looking at the patient, as you can see on the external appearance, there is a lot of scab, and as you can see on the nose, we divide normally nose into three categories. That is upper 1/3, which is bony, while the lower 2/3 is a cartilaginous part. Like I have a So as you can see on the lower 2/3 part, the cartilaginous erosions are there, and there is saddle nose deformity. The bones are a bit intact, right? So on the oral examination, palatal perforation was present, and the rest of the mucosa around it was congested and edematous. We did a nasal endoscopy of the patient. Right. So as we were going inside, can we go? Yeah. Right. So as we entered from the nose, you can see the vestibular area. There is excessive scarring and narrowing in the vestibule. The cartilages present over were highly thick and they were eroded. While going inside, you can see medially the septum used to be there, which is a cartilaginous and the bony part, which both of them are absent. You can see on the both sides of the nasal cavities can be seen from the single nair. There is no septum present. Laterally, you can see turbinates are there, where the mucosa is highly edematous and a lot of discharge is present. And you can see inferiorly a large perforation is there. The tongue can be visualized through the same cavity, and you can see the hard palatal perforation is there in the patient. So what we decided later on, we took a punch biopsy from the patient from the most susceptible area in the septum part. So coming on to the differentials. So differentials, as we categorize into three segments, one is the infective part. So in the infective, like the invasive fungal sinusitis, the first and the foremost what we think about it, which is very rampant in nowadays, especially in the post-COVID era. So we were thinking in this terminologies where you can see the points in favor is the nasal septal erosion, and you have a hard palatal perforation, and the nasal cartilages are also eroded. But what contradict to this part, or in this particular diagnosis, was the mucosa was unhealthy. And in invasive fungal sinusitis, you have necrotic turbinates and blackening of the new mucosa is there. Then second most common probable diagnosis is the granulomatous disease of the nose, where we can have the infective, that is the chronic granulomatous disease like leprosy and tuberculosis. And others can be connective tissue disorders like vaginous granulomatosis. So all these diseases, granulomatous diseases, they present with a similar presentation with nasal septal perforation and erosions. And along with that, they have an external cartilaginous malformations, which is present in the patient. And last, when we talk about the rest, we talk about the malignancies. The most common malignancy in the nose, what presents with these similar features, is NT-kel cell lymphomas. But these lymphomas are very virulent type of, and they have a midline erosions, where you can see in the patient they have a perforation, the septal perforations. So that's why we took a biopsy, and we were waiting for the other biochemical results and the HP report. Thank you. Yeah, yes, sir. I can hear you, sir. Yes, sir. Yeah, that's why we excluded it. So it's a differential, we have kept it. So we took a fungus as the most common, because that fungus particularly is very common in nowadays. And since the duration of the patient is from 6 months to 3 years, so it cannot be a acute infection. We have talked about the chronic infection. So in due course of time, the fungus has a tendency to erode things. And it can involve both the cartilaginous as well as the bony part. But the point contrary to this particular fungus we were talking was the patient did not had any complaints of abnormal paresthesia or anything of that sort, or epistaxis, because the fungus has a tendency to invade the neurogenic component of the nerves, and the patient develops tingling sensations in that area. Thank you. So I would like to call upon for Sir Thalor sir for primary discussion.
So, good afternoon, everyone. So now we were with to summarize the case. It was she was a 30-year-old female and was having skin lesions along with the palatal perforation and the nasal destruction. And the cutaneous lesions were in the form of, they were ulcerated, infiltrated plaques, mainly present over the face, but also present on the other parts of the body. So what are the differential diagnosis? I would like to ask the house. So case is open to house. So for the opinion on differential diagnosis. Depending upon the history and examination, I will go through the investigations later on, but on history and examination, and there's clinical findings like this palatal perforation, nasal destruction, then there's vegetative or warty looking ulcerated, infiltrated plaques. Well taken, ma'am. But the lesions, actually, there was no sensory loss and no motor weakness anywhere in the body in history. So,
medicine people will think what sir is also saying, if Wagner's can be a person. The same thing, medicine people will also think.
Wagner's granulomatosis, okay, yes. Generally, the lesion presents as medium vessel vasculitis in Wagner's, and means none of the lesions was presenting as a lesion of vasculitis, means sharply punched out lesions with a clear cut margin is the general cutaneous presentation of Wagner's disease. And there is always a history of allergic like rhinitis, pharyngitis, and then that preceding history was also not there. So Wagner's on clinical grounds we did not get. Tuberculosis, yes, we. So any more inputs? So we kept 7 differential diagnoses here. The first and foremost was the disseminated form of discoid lupus erythematosus. Because the cutaneous lesions were hypo to depigmented, the peripheral part was hyperpigmented, and they were present on the face, which is a commonest area to present in discoid lupus erythematosus. As the lesions were also present in the photoprotected parts and other parts of the body, so disseminated form of DLE was first gives. So we will go through each of these differentials in later slides after investigations. So first I would like to go through speedily what differentials we kept. We kept this differential. This was the only non-infectious disease. Apart from that, as madam has said, that tuberculosis is very common. So 2 of the types of cutaneous tuberculosis, lupus vulgaris and TB-VC we kept, multifocal variants. Then another infection like cutaneous leishmaniasis we kept at 4th place, and then tertiary syphilis. And two of the deep fungal infections like chromoblastomycosis and lobomycosis we also kept in the differential diagnosis. So then we proceeded for the investigations, a detailed workup of the patient done, and it showed this routine investigations including CPC, LFT, RFT, blood sugar, chest X-ray, ECG, they were within normal limits. On coming to specialized investigations, RT-PCR and viral markers were negative. Then this TPHA and VDRL test were negative. Immunological profile like C-ANCA, P-ANCA, ANA, anti-DS DNA was negative. Montauk's test was negative. Then her thyroid profile and ultrasonography of abdomen was within normal limit. Except raised ESR, ESR was 56. Except the raised ESR, all the findings were within normal limit. So I would like to invite radiology consultant Dr. Arpita Gupta to discuss about the radiological findings of the case.
Thank you so much, sir. Good afternoon, everyone. So, non-contrast CT scan of the PNS was performed, and we can very well see in these coronal and sagittal bone window images of the CT that there was presence of this defect in the hard palate, due to which there was formation of oronasal fistula. And there was also resorption of the cartilaginous as well as part of the septum of nose, and the inferior turbinate on left side. And we can also see mild mucosal thickening in the right maxillary sinus, and this mucosal thickening was also seen on this axial T2 weighted MR image, which was present on the medial aspect of the right maxillary sinus. And on these axial and coronal T1 fat sat post contrast images, we can very well see the palatal perforation forming the oronasal fistula, and there was presence of congested hyperemic mucosa around this palatal perforation along with congestion of the soft palate. And these are the volume render images which were obtained after CT. On the sagittal and frontal profile views, we can very well appreciate the destruction of the nasal bridge and flattening of the nasal bridge along with the flattening of nasal ala and mild flattening of left maxilla. And this is the submental volume rendered image after removing the mandible. We can see this defect in the hard palate. So I would now like to invite Dr. Surendra Thalor sir for further discussion.
So now we are with this extra finding of bone resorption along with the palatal perforation, nasal destruction and the cutaneous lesions. So to cut down some of the possibilities, we are going to discuss each of the differentials in tabulated form. So our first differential, discoid lupus erythematosus, the chronicity of the disease, the type of the lesion and the healing by atrophy, they were all in favor of this DLE, but what was against it was the history of photosensitivity was not absent, which is generally present in cases of lupus. And second was the lesions there is generally thick adherent scale which is present in the classical lesions of DLE, which was absent here. Rather, this crusting and this varicosity was present. Then nasal destruction and palatal perforation has also not been reported in literature in DLE cases. Our second differential diagnosis was multifocal lupus vulgaris. So it is a type, possibly form of cutaneous tuberculosis, where the lesions generally expand at one side and heals at another side. So this here, what was happening was the lesions were progressing all around. They were progressing centrifugally, which were against the lesions of this lupus vulgaris. Otherwise, the lesions, the morphology of the lesion was mimicking, because they also present with infiltrated plaques with superficial ulceration and crusting. Then third differential was tuberculosis verrucosa cutis, and which was also because Montauk's was negative and there was no history of systemic tuberculosis anywhere. It was also kept lower in the possibility. Then coming to cutaneous leishmaniasis, our fourth possibility, because patient was not belonging to the endemic area to the leishmaniasis, that is, patient belonged to Swimadopur, which is not an endemic area for leishmaniasis. And nasal and palatal perforation, they have already been reported, so we were about to associate these findings. And then tertiary syphilis, it was ruled out because of the negative VDRL and TPHA test. But still, the lesions of tertiary syphilis like gammas, they present with infiltrated plaques and superficial ulcerations, and they present with chronic nature. So that's why they were also in the differential, but they were ruled out. And there was no history of early syphilis like primary genital ulcer or skin lesions of mucocutaneous lesions of secondary syphilis. They were ruled out by these clinical findings. Finally, coming to chromoblastomycosis, chronicity and the lesion type were in favor of the chromoblastomycosis, but such widespread disease has not been reported, and nasal and palatal perforation has not, it's very rarely reported. Coming to the other last differential diagnosis, that was lobomycosis. So lobomycosis and this chromoblastomycosis, they clinically resemble to each other. Only difference is the progression of the lesions. Like in lobomycosis, the lesion starts as papule, this warty papule or plaque, and then ultimately changes it into keloid-like lesions. While in chromoblastomycosis, the lesions start as this normal papule or plaque, and ultimately varicosity and ulceration develops. So progression of the lesion was against lobomycosis. So we asked some investigations like fungal culture, KOS preparation from the mycology lab, pus culture sensitivity, and some fungal markers, but unfortunately all were negative. So now I would like to invite Dr. Sweta Agarwal from pathology. He is assistant professor in Department of Pathology to tell regarding the detailed histopathological examination.
Thank you so much, sir. Good afternoon, everyone. We received the skin punch biopsy of this patient in our department, where the tissue processing was done and hematoxylin and eosin staining was done. And the section under scanner view shows this is the epidermis and this is the dermis. The epidermis is showing marked pseudoepitheliomatous hyperplasia. This is the higher power view of the same, showing hyperplastic stratified squamous epithelium with downward extension of the retices. This is the island of mature squamous cell which is going deep into the dermis, and some infiltrate is also seen in the dermis. This is the another focus of the same section, in which the dermis is showing neutrophilic abscess formation and granulomatous reaction with many multinucleated giant cells, which can be better appreciated in high power. Here we can see many multinucleated giant cells. These are multinucleated giant cells. And this is the cluster of epithelioid histiocytes having sleeper-shaped vesicular nuclei with dense eosinophilic cytoplasm. This is the another focus, in which we can see these are septate fungal hyphae. One is here, another is here. So now we have pseudoepitheliomatous hyperplasia, neutrophilic abscess formation, and granulomatous reaction with many multinucleated giant cells and these fungal hyphae. So our differential diagnosis were mucormycosis, North American blastomycosis, phaeohyphomycosis, and chromoblastomycosis. In mucormycosis, there is extensive areas of necrosis and broad aseptate branching fungal hyphae are seen. These are non-septate.
In North American blastomycosis, spherical, double contoured, yeast forms are seen with broad-based budding buds. There is budding. These are double contoured. In phaeohyphomycosis, brown-colored septate fungal hyphae are seen. This is the past stain which is showing magenta color. Now, after discussing these differential diagnosis, there is a twist in the story. When we go back to the slide, which I have shown you earlier, these fungal hyphae are brown in color and septate. That means these are pigmented hyphae. So, pigmented hyphae can be seen in two fungal infections. One is phaeohyphomycosis and another is chromoblastomycosis. But the chromoblastomycosis must also show some spherical structures. So we got some multiple serial sections cut, and this is the section right now. And in this section, one can appreciate these thick-walled brown color rounded structures. Some are present in chains, some are in clusters, and as well as lying singly. These structures are known as copper penny bodies, sclerotic bodies, or medlar bodies. These structures have septa at multiple planes. Here we can see septa. Here, this is longitudinal septa. This is transverse. Here. So these are also known as muriform cells. This appearance is likened to European chestnut. There are many bodies. In this section, these sclerotic bodies can be seen within the giant cells. Here, this is within the giant cell. So these copper penny bodies or sclerotic bodies are the hallmark of chromoblastomycosis. So our final diagnosis was chromoblastomycosis. Now I invite Dr. Surendra Singh Tharor sir for further case discussion.
So our final diagnosis, as because these medullary bodies or copper bodies are very pathognomic of chromoblastomycosis. So this we were dealing with extensive cutaneous chromoblastomycosis that was leading to nasal destruction as well as palatal perforation. So where does this chromoblastomycosis lies in the spectrum of the fungal infections to the human being? And so to divide it, it is divided basically, the fungal infection to humans are divided into two parts. One is superficial and second is deep. And deep fungal infections are further subdivided into subcutaneous mycosis and systemic mycosis. So superficial cutaneous infections, they survive on the stratum corneum only. While the deep infections, some of them like subcutaneous mycosis, they go up to the skin and soft tissues, while the systemic mycosis which goes into the blood. The main difference between both these variants like subcutaneous and systemic mycosis is of the host factors. In subcutaneous mycosis, this host is immunocompetent. Basically, they happens to the normal persons. There is no immunosuppression at all in these patients. So all the subcutaneous mycosis, most of the time the host is immunocompetent. While in the systemic or deep this systemic mycosis, host is basically immunocompromised. So that is the main difference. And chromoblastomycosis is one of the 7 subcutaneous mycosis. So it is caused by a demacious fungi, generally inoculated by the trauma or direct inoculation, and has a wide variety of presentations we are going to see in coming slides. So this is also called demacious fungi, are also called as pigmented fungi or phaeoid or black fungi. So black fungi we have already heard of in the COVID pandemic about the mucormycosis, but mucormycosis is not the black fungus. In fact, that causes in mucormycosis the tissue, there is end arthritis and ultimately necrosis, so the tissue gives a black color. So due to that it is called black fungus, but real black fungus are pheohypomycosis and chromoblastomycosis, which produces pigment like in melanin or simulators of melanin, and then they are real this pigmented fungi. Two genera are commonly responsible. One is Fonsesia, second is Cladophilofora. And globally it is as such worldwide, but incidence varies from country to country. But it is more prevalent in tropical and subtropical climate. In Indian scenario, there was one good review published in 2017, and in it encompasses almost 1957 to 2016 all cases, and only 169 published cases from the India were there. So you can imagine the rarity of the disease. It's very uncommon infection as such. Mostly occurs in adult males who are engaged in farming or gardening. Pathogenesis, I will not go into details. 5 clinical morphologies are described. One is nodular, second is verrucous, third is tumorous, fourth is cicatricial, and fifth is plaque type. As we can see that our case was verrucous type of chromoblastomycosis. Coming to complications, tissue fibrosis and bacterial infection is the most common complication. Rarely it can lead to squamous cell carcinoma, and very rarely it can lead to extracutaneous involvement. Only 3 cases have yet been published from the world literature to cause systemic or extracutaneous involvement. One case was of oral chromoblastomycosis. Second was this chromoblastomycosis causing nasal destruction and cleft lip, and third was bone and CNS involvement. So all these 3 cases, they were in immunocompetent hosts. Although there was extracutaneous involvement, but all the cases were immunocompetent. So it can happen in the normal person also. So how to make a diagnosis for subcutaneous mycosis? I think history taking and clinical examination and histopathology, they are of utmost importance. And some things like dermoscopy, KOH preparation, fungal culture and serology can add to the diagnosis if found positive. Coming to the management, if it is localized, then physical methods are available. If it is extensive, then chemotherapy is used. And if it is treatment resistant, then combination therapy are used. And it is the treatment is divided according to the severity of the disease. And if it is less than 5 centimeter, then the size of plaque is less than 5 centimeter, then it is mild disease, and mostly the physical modalities like excision or Mohs micrographic surgery or cryotherapy, they are used. If it is moderate disease, like the lesions are of size between 5 centimeter to 15 centimeter, then oral antifungals are used. If it is severe disease, that means more than 15 centimeter of the single lesion or adjacent sites are also involved, then also oral antifungals are involved. And in refractory cases, either combination of the 2 oral antifungals or 1 oral antifungal along with some of the physical modality is used. So generally being used antifungal therapies are itraconazole, terbinafine, and the reserve drug for these infections is liposomal amphotericin B. So in our case, the treatment given was, we started the patient with itraconazole 200 mg twice a day for 1 month. There was no response. Then we added terbinafine 250 mg daily for more 1 month. And then also there was no response. Then we admitted the patient and started on amphotericin B. But unfortunately, patient developed hypotension secondary to amphotericin B. We needed to stop, and now we were in real dilemma that what's another antifungal we should use. So second generation triazoles, when we search the literature, second generation triazoles were found to have some efficacy in some of the case series. Like one case series we see with the voriconazole. Voriconazole and posaconazole, these are two second generation antifungals which can be used in this resistant cases of this chromoblastomycosis. So this series was exactly similar to our case. Our case was also not responding to itraconazole and terbinafine, but they gained only partial response with 12 months of voriconazole treatment. As we already know, but the voriconazole is cost effective. It is less costly than posaconazole and it causes less elevation of liver enzyme. So we choose voriconazole in our patient and started on 200 mg twice a day. The main side effect of it is visual disturbance and hepatic and renal dysfunction, but luckily none of these appeared in our patient. And this is the response to voriconazole. At 3 months, almost more than 60-70% improvement was there, and after 6 months, almost the lesions were clear and only dyspigmentation and scarring was left. So this was the same response was at other body sites also. So now means we made the patient fungus free, but still the quality of life of the patient she was also still she is struggling with that. So the morphological appearance of the face, like this nasal destruction, then palatal perforation, and the dyspigmentation, they were still there, and for that we seek opinion from the plastic surgery. And now I would like to invite Dr. Shah to speak upon what are the future plans of plastic surgery in this very patient.
Good afternoon, everyone. So, as Sir said, the patient is now disease-free, but still she is having complaints. What are the chief complaints of the patient? One is nasal regurgitation of the food. Second is change in voice. Third is saddle nose deformity. Fourth is difficulty in breathing. So, the first two we know because of palatal fistula, and the next two because of the nasal septal and cartilage resorption. These are the clinical pictures suggesting that the patient has saddle nose deformity, and this is the palatal perforation of the patient. So now what to do first? First, we would like to go for the palatal fistula repair, in which we will be closing the palate in two layers. First will be the nasal layer, which will be covered by the vermilion flap, and vomerine flap, and the second layer will be mucoperiosteal flap, which we will be taking from the side of the palate. As we can see the reconstructed image, let's talk about the future in that case. So in the prerequisite part, we need to make sure that the margins of the palate are fungus free. Only then we will be able to reconstruct the palate from the local region. So for that we need a histopathological evaluation also of the palatal perforation margins. Now let us come to the nasal deformity part. In plastic surgery, for the old time flaps, the gold standard flap to cover the nasal deformity is the forehead flap. Interestingly, it was designed by an Indian surgeon only in 1850s or some year. In this case, we will be taking the left paramedian forehead flap, which will be based on the supratrochlear artery and supraorbital artery. I have marked the artery and the region of interest which we will be taking. This blue part will be reposited or transposited over the nose. We will be having a look as how it will look in the next slide. So for this, I confirmed the artery via Doppler examination also, and the artery region was free of any disturbances. For the septal framework reconstruction, we will be taking costal cartilage as well from the costochondral region. So this is the forehead flap, already reconstructed forehead flap. As you can see, the forehead is having a linear scar which is primarily closed after taking the flap. But in this case, the forehead is scarred. So we will not be able to achieve a single line, suture line in the donor site. So what to do next? So we need an extra tissue. We need tissue expansion for this patient, for the forehead, for us to be able to take the forehead flap. So what we will do is we will expand the tissue in the forehead region. So for that, we will use tissue expanders. What are tissue expanders? They are nothing but inflatable silicone balloons. We will locate the balloon in the forehead. Over a period of 12 weeks, we will inflate the balloon with normal saline. During these 12 weeks, we can also achieve scar maturation. The hypertrophic scars that are present over the cheeks, those are really scarred and contracture is also there. So for that, we can go for silicon-based gel or Canacot-based gel during these 12 weeks. So after the 12 weeks, we can proceed with the forehead flap, which will somewhat look like this. So over the expanded region of the forehead, we have drawn the flap that we want, and we transpose it over the nose. After creating a deformity, after creating the defect, we transpose the flap over the nose. After 3 weeks, of forehead flap, we can go for detachment and insetting of the flap, and we can give the patient the beautiful nose she deserves. Sorry. Over here, we remove this bridge, we inset the flaps. So now one more benefit of tissue expansion of the forehead is that the scarred region of the forehead we can excise, and we can cover it up with the normal region of the forehead. We can expand this and cover the forehead with the normal flap. So in about 5 months, we have accomplished everything. We have reconstructed the palatal fistula and the nasal deformity of this patient. So what other options we can give is bilateral cheek scars and bilateral loss of eyebrows is also there for the patient. So if the patient is compliant enough and she is motivated, we can go for neck expansion, neck tissue expansion over bilateral region, and then we can go for advancement of the flap over the cheeks so that the scar has been removed. And for the loss of hair over the eyebrows, we can take a superficial temporal artery-based islanded hair-bearing flap. Over here, I can just remove a tissue and then burrow it, and then it will be looking like this. So we can burrow it and we can give her the eyebrows. So in short, first we will do palatoplasty, tissue expander over the forehead. After 12 weeks, we will remove the tissue expander from the forehead. We will do the forehead flap. After 3 weeks, we will detach, inset the forehead flap. We will place neck tissue expanders, and we will go for bilateral eyebrow reconstruction. And then after 12 weeks, we can go for bilateral neck tissue expander removal and the flap advancement. So I would like sir to continue for this.
So the take-home message from this very case is one is chromoblastomycosis occurs in the immunocompetent host. They are perfectly normal persons, but presents with varied morphology, so diagnosis is delayed. So should be histopathology is the crux to make diagnosis, along with the initial suspicion. High index of suspicion should be there, and then this recalcitrant nature of disease is there. So from initially only there should be aggressive treatment, and voriconazole proved to be a very good alternative to amphotericin B as depicted by our case. The most important thing which were different, our case was different from all the published literature, because in only single case there was nasal destruction. In same patient there was palatal perforation and such a widespread disease which has not been reported in worldwide in any of the literature. Thank you for patient listening.
Thank you, Department of Dermatology, for such a wonderful case presentation. Now I would like to invite Dr. Monica Jain ma'am to give the vote of thanks.
So, good afternoon, everybody. So today was a luminous CPC. नाम से ही साबित होता है, दीपक माथुर sir. So it has to be luminous, and the team has rocked. Dr. Surendra Thalor has done a wonderful job. I must congratulate the subsequent department like pathology, even the plastic surgery, radiology. They have done a tremendous job. And of course, the one more thing which I wanted to announce is again re-ensuring that we all need to create a very good crowd, especially of PGs, faculty, whoever are free. There was a issue regarding what should be the idealistic time. We'll be communicating you with the same after discussion with the honorable principal and controller, sir. And after this, I just want to announce one more important thing, that one of the resident, that is Dr. Vankam Ashish Verma, has done an immense oral presentation on a very noble topic, that is parasitic twin with anorectal malformation or caudal regression syndrome sans sacral anomaly in prestigious conference of 31st Pediatric Colorectal Club, Bologna, Italy. So big round of applause for our resident, and it was done under the supervision of Dr. Praveen Mathur, pediatric surgery senior professor. I'll invite Dr. Dinesh Mathur sir to please come up, and I will invite our principal sir, Dr. Deepak Maheshwari, Dr. Deepak Maheshwari sir, and Praveen Mathur sir to kindly come up and honor the student with a certificate of appreciation. Congratulations. I also request our principal controller to give a moment of remembrance to Dinesh Mathur sir. A big round of applause should continue, and I will request ID Gupta sir, SM Sharma sir to please come up. Congratulations, sir. I would just like to thank the entire CPC team, Dr. Puneet, Saxena sir, Madhulata, Aradhana madam, Shruti, for the immense effort for conduction of this CPC. And next time, I can vouch upon, because something will be done at the principal end, that the crowd will be full. Thank you very much for patient listening. All are invited for the tea and samosa.